I'm Eva Kalmus. I am indeed a portfolio GP. I have a funny old mix of jobs. I do a little bit of general practice. I work at a community hospital at the New Epsom and Newell Community Hospital, and more recently I've been providing some medical support for the virtual ward, both at practice level and a little bit for Mid-Surrey. And it's really interesting because it fits with my commitment to care for the elderly particularly, and getting the professionals who help them to work together. And that's something I feel really strongly about. We can't help our patients unless we can work together. We do need technology to support us. There is no doubt about that. Just the numbers and everything else tell us that that's the case. And we've obviously heard some very convincing arguments about that. And I think it's true. As long as we're aware that the technology is serving what the clinicians and all the other people who work towards patient care are doing, it's something which serves our agreed objectives of improving patient care. I'm bringing my talk right down to a very basic level. I'm going to talk about two patients for whom telehealth hasn't been available, and I don't have practical experience of it, but for whom it might have been useful had it been available. In fact, it probably would have been extremely useful as long as it's understood what it can do and also the bits that it possibly can't do yet. So these are my two patients. 50-year-old man had a high-pressure sales job and was admitted some months ago to the acute, having had several strokes in a very short space of time. Life had been stressful. Unfortunately, he'd been diagnosed with high blood pressure some years before and had been too busy to take on lifestyle advice, medication, any of those things, and had ignored the advice. And this was the sad outcome in his case. Had a long inpatient stay in a hospital, which had multiple complications. So from having been a fit man supporting a family, he became, unfortunately, quite significantly disabled by the strokes, but also to some extent by the other medical conditions which he'd had, further strokes, myocardial infarction and poor kidney function. He then underwent a period of specialist neurorehabilitation, which did result in some improvement, so he was discharged home. Unfortunately, his blood pressure remained very poorly controlled a lot of the time, despite good compliance in hospital. So clearly on discharge he was going to need ongoing blood pressure monitoring. And so he was referred into the virtual ward, who provided community matron and healthcare assistant regular review, as in at one point twice daily measuring of his blood pressure. Clearly a huge amount of professionals' time was being spent going in to see him. So I suppose the questions that you're left with at the end of this is who's measuring his blood pressure when he's gone home, but also who looks at his medication, who looks at how this fits in with the rest of his lifestyle. He was quite symptomatic at times when his blood pressure was either too high or too low, and so obviously it takes a whole package. Now, telehealth clearly would have been extremely useful to go on monitoring this man at home. When I rang to have a discussion after discharge, what did they think, family-wise, of the possibility? This is someone who's experienced in the use of technology because of his previous working life. They weren't against it, but their question was, does that mean the nurse won't come and see me? And I think we have to keep that one in mind, that we're not losing the patient contact, but the telehealth would have been absolutely crucial, probably actually in improving this patient's care at home. So that's my first case. The other one is an 80-year-old man, again, generated by the risk stratification tool that we've just heard about as being high risk of admission. So has a regular GP who knows this patient quite well, multiple admissions, with exacerbations of chronic obstructive pulmonary disease. So I went to review him in this particular case and went through a number of issues which were confronting him. Clearly his functional level has been declining for some while, quite symptomatic, and has some other complicating medical conditions. Probably the most significant in some ways was his dementia. He'd been diagnosed with dementia, and basically the diagnosis had been made, but he was now beginning to rely very, very heavily on his wife as his carer. Went through a medication review, was mentioned in the first talk as being an essential part of reducing admissions, and I think it's the fact that this takes a lot of time. This needs input. You need the data, which telehealth can provide, giving you the background, and then beyond that you need a clinician to take a look at that data, and obviously it's a skill that we're not used to, looking at pages or a summary of people's blood pressure or their oxygen saturations and deciding how we adjust things in response to that. So there are new skills to be learnt by the clinicians, how to deal with this massive data that you're going to get presented with in a format that you can then use to improve patient care. I've mentioned some of the things that were changed as a result of the medication review. Personal contact was needed, and I stress this again, in the course of the home visit, the wife was given some general advice about benefits she might be entitled to, entitlement to a blue badge, and of course the possibility of social care involvement, which is going to be needed sooner or later in this household. I've written the rest of the story out of what happened to this man. He has had further admissions following this, and other referrals have been needed. However, with home oxygen saturation monitoring, blood pressure monitoring, this would have added to his care. I have no doubt about that, because it would have given a picture of what happens on a good day, what happens on a bad day. He was clearly experiencing a range of how much he was able to do, and was putting his wife under a lot of stress. So I think if it had been possible to review data as well as doing all the other things, it would have been very, very helpful for this patient's care. And reminders of education. There were things that were clearly missing from the medication that you think, actually, I don't believe that the GP hadn't provided a reliever inhaler. It's very unlikely. Somewhere that had got forgotten. There are ways that this could have been given to them. Look, you're not feeling so well. What about adding in this to your medication? So I think there is a lot of room for use for telehealth, but I think the question also is making it clear whose responsibility it is to respond to these alerts that would, certainly in this case, patient's case, he would have been generating a lot of alerts. I'm sure his blood pressure was outside range a lot of the time. I have no doubt that his oxygen saturations were outside range a lot of the time. We have to be very, very clear who is responsible for responding to this and how we get appropriate levels of response. So obviously this all has to be integrated in introducing telehealth. Okay, I put a couple of references. I was reading around thinking I really ought to know something about this before I talk. I'm not an expert at all. And interestingly, I don't know if anybody caught the Radio 4 In Business programme about nearly 2 weeks ago now about growing old. So it was put in the context of the economic situation we're in, and reported on the studies from Newcastle, 1,000 people at the age of 85, nobody had no long-term conditions. None of those 85-year-olds had no long-term conditions. The average was 4, 5 or 6. So we've clearly got a problem. That was a very interesting report, and they quoted, I think you mentioned about the new introduction of telehealth, and they quoted some patients from that and their reaction. There was something in the British Medical Journal quite recently: be wary of signing costly deals for telehealth technology. Although some technologies could help people with long-term conditions live independently, they must not be a substitute for effective services and must be wired in to well-coordinated support. I think that's where the virtual ward comes in. I think that's where working together with social care comes in. And it must be where working together with the acute consultants also comes in, because at the moment, these patients are bouncing in and out of hospital. Everybody knows that that's not the right answer. But as a whole package, telehealth can, I'm sure, contribute to reducing those admissions, but most importantly, providing them with better care at home. Thank you.